All right. Thank you very much for the introduction, Dr. Thank you, Dr. Badr, and Dr. Ahmed for this kind invitation. So here's the roadmap of what we're going to be covering in the next 15 minutes or so. I'll kind of highlight the role disease registry play to inform improving population health. And then we'll kind of shed some light onto some of the potential role electronic health records plays in shaping future data generations. We all know that data generation is gaining huge momentum in the kingdom now, and with the increased reliance on electronic medical records, definitely this will increase in the future. Then we'll conclude with a couple of recommendations in future direction. So unfortunately, Saudi Arabia is a developed country, but face a huge burden when it comes to non-communicable diseases. Unhealthy lifestyle is prevalent. Obesity is on the rise. We have about 50–60% of the population either overweight or obese. We know that will play a role in many health conditions. Currently, as we speak, there are about 8 million individuals in the kingdom with a chronic condition. This number is expected to increase to 10 million in the year 2020. So imagine how that was going to play in our future burden of premature mortality and healthcare costs. We already know that premature mortality in the kingdom is much higher. Premature mortality is defined as death happening way earlier than the expected time. It is around 46%, much higher than developed nations. This also affecting health costs, and now with the healthcare transformation, health cost is playing a major role. About 4%, according to the Ministry of Health, increase every year in healthcare costs. So imagine the 8 million is becoming 12 million people with chronic conditions. So all of that, unfortunately, is going to pose an unsustainable burden. How do we address that? First, we really need to set the baseline. We really need to understand the burden of various health conditions. This is the first step, understanding your baseline and then moving from there. So there's various ways to do that. We can rely on primary data collections. You're basically collecting your own data. And that's, if it's nationally representative about sickle cell anemia or any health conditions, it's really important to inform clinical and policy. But we know this is expensive for any disease. If you want to collect data nationally representative, you're going to spend millions of riyal to do that. And it is unfortunate leading us to much reliance on US-based data or North American data. Alternatively, you can try to rely on what we call secondary data that are collected already from other sources, either from colleagues who already have a database or a national database, like a national survey, for example. It's cost efficient, but again, it does require initial investment, which again will be in the million. The other thing, a limitation, is that sometimes the data quality may not be as good if it is collected by the researcher themselves. So hence comes the roles of disease registry. They really help us set a baseline where we stand. And once we set the baseline, we understand the prevalence, then we can move to risk factors that either increase or reduce the risk of disease, complications, patient-reported outcome, as Dr. Mansour had mentioned. All of that is really important. Then the following step is design and implement clinical intervention, policy intervention, and then evaluate all of that. all of that is definitely going to play a role in something that you're going to hear a lot about in the next few years. And Dr. Mansour alluded to that briefly when he mentioned Medicare paying for performance. So in the kingdom, as we move in the next few years, we're going to hear a lot about value-based care. And probably many of you have heard the concept before, right? Essentially, value-based care is where we should be heading. We should be rewarding good performance, good outcome, rather than just a fee-for-service or a capitation mode where it's mostly prevalent. So how is that related to disease registry? It is related to disease registry because outcome is in the numerator. And disease registries are a major source that we're going to guide us about outcome. Other countries, especially in Scandinavian countries, have far surpassed Middle Eastern countries in terms of investing in disease registry. Sweden is actually one of the leaders, and one of the analysis by BCG company estimated that they saved about $7 billion in 10 years just from investing in disease registry. A huge registry in Scandinavian countries that kind of captured the patient from birth till death. Imagine that trajectory and the data infrastructure. So in addition to their help in improving health outcome, they do save cost on the long term. Other application is that really with comprehensive registry, we can understand local burden, national burden, GCC country, internationally, benchmark where you stand for any disease across the globe, as well as doing some sophisticated or dashboards to understand variations or what we call hotspotting within the kingdom. However, this is all nice, and definitely when speaking with researchers, clinicians, they really admire the notion of investing in disease registry. But the problem is when we sometimes talk to policymakers, they are competing priorities. You know, especially researchers. Researchers want to spend a lot of money on research. We know we're not spending enough on research in the kingdom, but sometimes there's competing priority. No, we have to treat patients. We have to train medical students. Those also cost money. So from the perspective of efficiency and competing priority, sometimes we have to rely on other or what's available. And this is what has been done in other countries. So in the United States, this paper came out, I think 2016, 17. It kind of argued that there is innovation in population health surveillance. And they stated that in 2004, 20% of physicians were using electronic medical records. This number jumped to 87%. This is a huge jump. And I would assume the same jump was achieved here in the kingdom. Many physicians now use electronic health records. So how can we leverage that to improving our understanding of disease burden and hopefully establish disease registry? Luckily, we're not alone in this. There's huge momentum in the kingdom as part of the transformation for value-based care, value-based healthcare. There's also huge interest in digital health, electronic medical records. One of the aspiration for the transformation program is to have an electronic health record for each individuals. This will drive big data and understanding disease burden, as well as sophisticated analysis like AI and machine learning. So electronic health records have the advantage of population coverage. So I'll speak about the National Guard population. So we have a stable population, National Guard individuals. They are eligible, covers the entire system. There's integration across specialties, orthopedic, pathology, hematology, and so on. So you have kind of all the information from the various sectors. And lastly, there's longitudinal continuity. So you know when the patient is diagnosed, and you know when the patient is discharged or died from the hospital. So you have kind of a cohort within your system. So if you design it correctly, you can really have a powerful database. So currently, so I work with many clinicians, and many have a strong desire to create a good data source from electronic health record with minimal human help. So I'll just spend a minute highlighting our current abilities, at least within our system. So luckily we have many registries in the National Guard, some of which are renal, diabetes, heart failure, and stroke. And within those registries, we can identify basic demographics, so age, gender, marital status, occupations, all of that without the need for human intervention or people collecting the data. Diagnosis, ICD codes, if the data is coded correctly, is captured, as well as lab measurement in some clinical outcomes. So that by itself, if you're really conservative in your registry or your idea of a registry, this by itself could be created for the researcher. Where we struggle, another tool or a tool that we usually complement this is what we call REDCap. Many of you are familiar with it. So if we have the data structured and clean, extracted from the medical record system, we can easily import it into REDCap, and voila, here's your registry. What we struggle with, however, is unstructured text. Basically, physicians' progress note, discharge summaries, and sometimes radiology finding. And ideally, you would want to have everything in your electronic medical record structured so you could really mirror whatever you want, but reality is that this is not the case. However, one of the things that we can invest in, and we're trying to invest in, is how to prioritize or how to identify our interest within the unstructured data for us to be able to extract automatically what we need. And I'll show you an example of some of our recent work. It's related to diabetes and hypertension. So we have a diabetes registry. We have interest to capture hypertension as a comorbidity. So within our system, we try to identify all the diabetics based on ICD code, based on medications, and based on lab results. So we got X number of patients. We are not 100% sure that those individuals are all the diabetic within our institution. So what did we say? We said, okay, this is the initial number we have. We know physicians in their progress note write the word patient have a history of diabetes, DM, HTN. It's a very common, and I got this from a physician colleague. So what we did is that after we identified the final number, we extracted around 10,000 patient progress note that are labeled not diabetic, not hypertensive. And what we did, we collaborated with a bioinformaticians who use in natural language processing to read those notes and flag the patient as diabetic if the word DM, the physician wrote the patient has DM, not history, family history of DM, but the patient has DM. And we found around, with 10,000 patients, 1% of them actually were diabetic, despite the fact that we did not have ICD code for diabetes, we did not have any medication, no records. From 10,000, about 160 patients, we went and read the entire 160 patients, and they were actually, in fact, diabetic. So kind of a small step in that latter. And this is the kind of momentum we're looking for, is basically relying on structured data and then complementing that from, with tools like NLP. Luckily, there are some efforts within the hematology fields. I really like to see some of the registry. I really hope to see much more. With the reliance on electronic health records in the kingdom, we could definitely expand that coverage. The beauty of electronic health record is that it will allow you linking comorbidity from various registries. So I highlighted the example of stroke, renal conditions, all of that condition. If the data is really updated, you can link them across diseases. This will reduce cost. And finally, we heard today about electronic the randomized controlled trials being on the rise. Disease registries will be a great tool to identify patient or candidate for various interventions. This is not to say it's easy tools, definitely have some challenges in terms of the data availability. The system has to be mature enough to extract those information for you to your registry. There's a huge cost or initial cost of implementations of the electronic health record. Not all the hospitals in the kingdom has it, but if they do, and they do allow extracting the data, this will be huge. Quality and reliability is a major challenge, even in mature hospitals like National Guard. The physician have to write an accurate ICD code, otherwise garbage in, garbage out. And finally, there's huge limited experience in that area. So we're really lacking experts who are able to analyze large data, who are able to conduct sophisticated statistical analysis. In terms of recommendation, I highly recommend working in multidisciplinary team. And I think this is some of the, or why we're able to achieve several registries, working as physicians, epidemiologists, bioinformaticians, and IT. Unfortunately, in many organizations, the IT works in silo. You really need to engage IT with a multidisciplinary team to be able to understand what can you extract and what cannot you extract from the system. And the other thing is, in working with so many researchers, many have great ambitions, and sometimes it's unrealistic given the resources available. So I highly recommend starting small, starting with one disease, starting with a registry as small as just the ICD code and basic demographic and patient outcome, and getting your residents, maybe an intern, to complement these registry. Once you have few paper coming out of this registry, it's a really proof of concept, and then you can promote it either through the partnership with the private sector to expand that registry, rather than staying put without progress because you wanted something expansive. And finally, and this is one of the things that we're definitely going to see on the rise in the future, is integrating various technologies. So you as a clinician working with a patient, you can easily ask the patient to give you their iPhone and look at their physical activity. This is an accurate measurement of the person's physical activity compared to asking them, do you walk 5 miles a week? So this is a technology within your hand, an iPhone, an iWatch, that could be integrated with the electronic health record to complement some data, either physical activity, it could be drug adherence, and so on. And we know this is on the rise in developed countries, so we might as well jump into that ship sooner. That's all I have. Thank you for this opportunity, and I really enjoyed the conference, and I'll be more than happy to receive any question with the great panel.